Hi, thank you. Good morning, and it's nice to be here. I haven't been in Israel for 25 years, and so it's lovely to come back and to this morning in Herzliya to see all the people running on the beach. Made me happy. Who here is a runner? Oh, good. So what I'm going to talk about this morning is some of the stuff we're working on at Hospital for Special Surgery. We have a running clinic and a running center we're developing and looking at ways to keep people running and on the road and injury-free. So in my role as a sports medicine doctor and as an advocate of people moving and running, I try and keep my patients moving all the time and running all the time, whether they want to finish any marathon or just run a 5K. As long as they're out moving, like I saw this morning on the beach, we want to keep them going. So we're going to talk about how you can keep yourselves moving and hopefully not hurt. So this is a typical person in New York now. This is July, so starting next month, we get everybody that wants to run the New York City Marathon. Has anybody run the marathon in New York?
Yes, well, we don't see this typical person.
Exactly. This guy in the back ran. That's good. You had a good time?
Yep.
All right, good. So this person comes in saying, typical patient visit. I'm doing an accelerated. I'm a New Yorker. I have no time, and I need to run the marathon, and I need to train very quickly. I'm going to push through the pain. I don't care if this hurts. I can do this. And they end up with this kind of story, which is ephemeral neck stress fracture. And unfortunately, just had one of these right before I left yesterday in the office. And so this is a very serious problem when it happens for our running population. We're going to talk about what runners are, who they are, why they're different. And I'm going to start this talk with some pictures from a great ad campaign from Adidas, who made a whole campaign that runners are different than the general population. And so the things that are normal for runners are great for runners, but they're very different. So you see these guys running uphill next to the trolley in San Francisco. You see this guy stretching his hamstrings in line at the airport. This mom looking at this mom. Normal behavior. And normal behavior. Idea being, what's normal for runners is not normal for the general population, but we want everybody to get out and to move. So we're going to talk today about some of the history of running, a little bit about if we should be encouraging our patients to run. And I know there's a physiology tilt to this. I'm not going to touch on the cardiac physiology issues, but my strong feeling is that the cardiac risk that's been put forth about running has been very overstated, in my opinion. We're happy to answer questions about that. Why runners get hurt, and what strategies we can think about to prevent running-related injury going forward, for not only for everybody in this room, but for the people you deal with. So I start this by saying that I want my patients to run. I think it's a great way to stay healthy. I'm going to talk this afternoon in the plenary session about a whole program around promoting community fitness that I've developed in New York, and talk about getting people out exercising. I saw a boot camp this morning on the steps in Herzliya that made me happy. I'm a big believer in that. So I want my patients to run. People have been running for a very long time. There have been depictions of people, 500 BC, depictions of people running for a long time. There have been attempts to study the healthiest way to run starting in the late 1800s, looking at what's the most effective way to run, because if you look at people running, people do it differently. Is there a best way to do it? What do we know about running and longevity? We know that basically runners live a longer, healthier, less medically costly life. So in the United States, we're dealing right now with a lot of issues. You may be reading about healthcare and spending on healthcare and people being mad about spending on healthcare. And as I'll talk about this afternoon, part of the problem is that we spend a lot of money treating diabetes after it's already happened, treating heart disease after it's already happened. We don't spend enough emphasis thinking about getting people out, preventing disease by moving in the first place. So we know that runners live longer, healthier, happier lives. A study of almost 18,000 people published looked at 1,878 runners over a 20-year period of time. Age-adjusted longevity was 6.2 years longer for men, 5.6 years longer for women. And running and the running boom has caught on around the world. It's been kind of the second running boom. Started in the U.S. and now exported around the world. There are 48 million runners roughly in the United States. 10 million runners more than 100 days per year. There were 137 people in the first New York City Marathon. In 2014, there were 50,000 people running across this bridge in New York. And so there's a huge popularity around the world around getting people to run. Now, runners end up with injuries, and the data on running and running injuries, somewhere between 20 and 50% of runners will get an injury at some point. Well, there's been some attempts to look at this. Just starting by this meta-analysis of 15 studies looking on running studies over an 8-year period of time. Just the basic conclusions were that runners were at higher risk if they were older, and women had previous participation in non-axial sports, so swimmers who became runners. They ran regularly on concrete, they ran a marathon in the past year, they ran more than 30 miles a week, or they didn't change their shoes. Men higher risk if they were restarted running, had a history of previous injury, had no running experience, and weekly distance of more than 25. Again, no huge information here, but just to say the injury sites were common in both from the waist down. Hips, knees, shins, feet were common in both men and women. So we know that injury rates vary. Studies published between 19.4 and 79% of distance runners have previous history of injury. And there have been some attempts now to look at what causes runners to get hurt prospectively, not just retrospectively. Too few or too many miles has been implicated in running injury risk. And so when we start thinking about all these things, what do we think about? We think about what keeps runners healthy, what keeps all of you running, what keeps me running, what keeps our patients running. And the answer is there are different things for different people, and different runners have different needs. Stride length, arm swing, minimal up and down motion, cadence, foot mechanics, strength, a good training program, nutrition, and recognizing injury, because different runners, depending on what they're doing, what their age is, have different needs. And so not every runner is created the same. So we're trying to think at the hospital about what are the best ways to run and what we can do to encourage our patients to run in our running clinics. Is there a best way to run? There are many ways to run. That slide of Paula Radcliffe running on a treadmill made me think of, she had probably one of the ugliest running styles I've ever seen in my life. It was very efficient for her. So there are many ways to run. There's no definitive best way to run. But there are some certainly general trends that we've been looking at in terms of what's been helpful, and we think about this as kind of a runner versus the ground. And so what we can do to minimize the contact points between runner and the ground, including foot and ankle motion, knee and hip motion, eccentric muscle strengthening, and cartilage function all relate to these issues of runner versus ground. And this becomes further important when we look at joint loading forces, walking versus running, and the significant increase of running loading force on the skeleton. And this really can have implications throughout the gait cycle, but walking versus running, in the running patient with the double float phase, you have a much higher impact force on the ground, so you're hitting the ground with a higher velocity, which causes more significant problems. So the typical patient is, in my office, not built like a Kenyan, all right? They love to run, they want to succeed, they're motivated, but they look more like this than they do like looking like Kenyans, all right? That doesn't mean we shouldn't encourage people to run. We want everybody to run, but their needs are different. And so when we start thinking about this, what are the things that we can fix? What are we looking at in terms of keeping people on the road and healthy? So thinking about kinetic chain, foot mechanics, stride mechanics, training plans, nutritional issues, and total body strength are things that we start thinking about when we start thinking about keeping people healthy instead of injured. So we'll talk a little bit about what we're doing in each of these realms. This is one of my boot camp classes in Central Park that I've been running, and I'll talk about those this afternoon. We started about 4.5 years ago with a very small group, and we just had a class I'll show on Monday for 1,000 people on the flight deck of the Intrepid. So it's really kind of growing, and it's exciting to be part of the prevention discussion rather than just the treatment part of the discussion. So running injury and kinetic chain mechanics, thinking about how every runner is built differently, and thinking about their basically underlying anatomy, their ankle and foot mechanic, the biomechanics of their whole kinetic chain, tip to toe, and recognizing that misalignment of any particular piece of that kinetic chain can lead to injury is very important when we start thinking about the concept of healthy running. So what's the optimal kinetic chain management program? Some combination of flexibility and strength. Runners have the distinct, unfortunate advantage of wanting just to run. They just want to run. They don't want to do the other stuff that can lead to prevention. So we start thinking about that, and that's an important piece around kinetic chain management, and I'm a big believer in getting people to do that. What about foot mechanics? There's been a lot said about the optimal foot strike and foot strike for runners. We first talked about heel striking, and then we talked about midfoot, then we talked about forefoot, then we talked about barefoot. Now we're back to talking about midfoot, and the answer is there's probably no right answer. There's no right answer for any particular person. We know that the ground reactive force initially on contact is highest when the heel strikes first, and so this is a typical heel striker in the solid line, a rear foot striker, and looking at the impact ground reactive forces from the heel striker, that's where the people are hitting the hardest. So there's been some push towards dropping, less drop in the shoes. This is an 8 millimeter drop between the heel and the toe. This is a zero drop shoe with no drop in the toe, and the concept is that if you have a less drop in the heel, you're less likely to hit your heel first. You hit your midfoot or your forefoot first if there's no drop. So people have been experimenting with 4mm drops or 0mm drops to try and get people to reduce their injury risk by landing further forward in their running stride. And it sounds great in theory, but the answer is it doesn't work. And so the goal is to try, as I'll talk about, to shorten your stride in the shoes that are comfortable rather than try and get fancy shoes that don't do anything at all to change your foot mechanics. So do shoes affect injury risk? There hasn't been a big difference with drop shoes, 10mm, 6mm, and 0, in several studies looking at shoe drop and injury risk. In fact, some studies have looked at the opposite effect of ground reactive force in this. So the shoe concept sounds great, but it doesn't seem to work so effectively as we might think as it did. In our lab, we've been looking a lot at studying foot mechanics and where people strike. So this is a typical forefoot striker, hitting with the front part of their foot, and many people are natural forefoot strikers. We think that's probably a good forefoot, midfoot way to land. You may not have ended up in the medical tent in the Tiberias Marathon if you've been doing some of this, but the idea is to kind of lessen the ground reactive force by trying to hit the forefoot, midfoot if you're able to do that. Not everybody is. Midfoot striker hitting again right in the middle portion of the shoe, and so what we've been doing now is getting people who have had injuries in, or not injuries, and we're really able now to analyze their run mechanic and figure out strategies to work on prevention for them. This is a midfoot striker, and this is a typical heel striker I was talking about before, heel hitting first, and so trying to make people land comfortably, and if possible, discourage that heel striker, are the two things we've been working on more. We've been doing this less with shoe wear and more with cadence. What about foot mechanics in running? A lot of interest in foot mechanics, getting people into corrective orthotics with tib post tendinitis or medial tibial stress syndrome from rolling in too much. Patellofemoral pain, runner's knee, another common diagnosis where we have put people into orthotics. The general assumption is that correcting the foot corrects the issue. But there have been a couple studies recently, this published in the British Journal of Sports Medicine in 2014, of 927 runners with 1,854 feet, they both had 2 feet, 250 km running pronators had lower injury risk than those who didn't. So again, turning that idea on, that every person is different is the answer to this. So there's not a one-size-fits-all. What about run mechanics? Runners running 18 to 40, 20 miles a week, injury-free at time of enrollment for 6 months prior. This is one of the first studies done looking at figuring out who prospectively will get it. All the running injury studies to date have pretty much been retrospective. There's been some work now looking at prospective, who's going to get hurt. So the next couple things I'm going to talk about are prospective studies. So this published looking at runners in these following categories: 18 to 40, they had to run more than 20 miles a week and no injury for 6 months at time of enrollment. Only heel strikers were enrolled in this study looking at gait mechanics, vertical landing force, and they were studied for a 2-year period of time prospectively looking at who was going to get hurt. So what are the things they found? Well, first of all, that all injuries, basically this is the age demos on the top, this is the mileage on the bottom. So if they were not injured, 117 versus uninjured, 107. If they had medically diagnosed injuries, 120 versus 94. So they had more significant injuries if they ran more mileage, so not surprising. The surprising piece about this, though, was that impact-related variables are higher in those with medically diagnosed injuries, so people who were hitting the ground harder had a higher risk of injury. Again, makes sense. How do we think about making that less? How do we think about getting people to hit the ground? Again, these were all heel strikers. How do we think about changing those variables? What about stride? And I think some of the new work on stride is interesting to me, and there are a couple ways to start thinking about stride, the stride mechanic. Stride frequency and injury rate. This was actually just a poster at the American College of Sports Medicine meeting in June of last year, looking at prospectively looking at 28 runners, 9 men, 19 women, training for a half marathon. Those who had cadence below 163 had an injury rate of 66.7. Those who had cadence above 168 had an injury rate of 22. So again, thinking about cadence is, I think, where some of this is interesting to me, much more than thinking about shoes and thinking about some of the other variables. Getting people to quicken their cadence. How do we do that? Well, you want to shoot for 170 to 180, and there are a couple different ways to do that. Most people, or many people, run with their smartphone, and there's a metronome you can just get for free as an app, and set your metronome on your phone. It's not very good music, but set your metronome to 170, 180, 175, and just try and match your footfall to that. That's one way to do it. This is a great app we use. We use this a lot, Spring. So Spring takes music, and different than Spotify, which will take your pace and pick music based on your pace. So if you have a bad behavior, if you're a 150 cadence runner, it will pick music at 150, so your bad behavior is reinforced by bad music. If you are looking at with spring, though, what these guys are doing is they're taking the music, you pick your own cadence, and then it'll play music based on the cadence you want to do. So it will make you aspirational. If you want to run at 180, you pick music at 180, and you'll be running at 180. So it's a much better way we use this a lot and to try and get people to shorten their stride and quicken their cadence. This is some of the newer stuff out of California, out of San Francisco. This group, Lumo, is coming out with a new generation run sensor that clips on your back, right in the small of your back, and it does everything from stride length to ground reactive force, etc. We've been looking at this. We're not sure about this yet, but that's some of the newer technology around that. This is a great app. This is a great British app, actually. Called Help I'm Being Chased by a Zombie, which it's a 5K, which encourages stride and basically keep people going so they don't get caught by their zombies. So developing your own training program, build up mileage, is there a one-size-fits-all? And the answer is no. Everybody's built a little bit differently, but a couple questions that we commonly hear. And number one is, if I run a lot, I'm going to destroy my knees, I'm going to destroy my hips. And we have a good word for that in Kansas City, where I grew up, which is called chazarai. That's not true, and we don't think that running at all causes increased risk of OA in the knee or the hip. A couple studies looking at this in a big population, 70,000 runners studied every 7 years, reduced OA risk was more due to genetic issues, etc., than it was due to running per se. So this is some of the data out of that, looking at basically people having males and females in that big study group, runners versus walkers, hip replacements versus runners versus walkers, and looking at BMI, again, runners versus walkers. So the runners were thinner, they had a lower relative risk of OA and replacement going forward. Now here's another interesting study that was just published last year looking at, and I wouldn't have wanted to be a volunteer in this study, looking at intra-articular cytokine and some of the precursors for inflammation in joints. So this was done in Boston, where they took 6 running subjects, both running and non-running subjects, 1 week apart, and each group was in both. So they had six people in the running group, 6 people in the rest group, and then they switched them, so each were in both groups. They had a control group, and they had a group that just sat for 30 minutes. They measured ground reactive force, cadence, and both blood and synovial fluid cytokine levels. So they tapped the knee, which if you have no effusion in your knee and that's not something you really want to do once, let alone twice. So I don't know what they encourage people to do to volunteer for this study, but doesn't sound too appetizing. But the issue around this was that basically the precursors of inflammatory response in the runners were actually lower than in the non-runners. And so the thinking was that the pounding, particularly IL-15, the pounding of running was in some ways potentially protective to the joint and the precursors of inflammation versus the people who are not moving at all. There's a guy at our hospital now, Howard Hillstrom, who's doing a lot looking at cartilage mapping of medial and lateral meniscectomy patients, runners versus walkers, looking at loading force in the medial and lateral menisci, walkers and runners. And what he's looking at now is looking at basically even with a 15-20% meniscectomy, the effect of running versus walking in the partial meniscectomy. And the issue is that the lateral meniscectomy patients have a significantly higher risk of overload of that lateral compartment, even with a 15-20% meniscectomy. So we're really encouraging people to think about holding off on any kind of surgical intervention if they're runners, particularly in the lateral meniscus, for some of the work he's doing. And then finally, I want to finish with some commentary on total body strength, because people I talked about just that want to run and run alone is the general demographic of runners. We want to make sure they think about that kinetic chain management and strength training. So I've been a big advocate of recommending functional strength training. And so some of the issues around total body strength and running, as people get older, their stride decreases and they lose body strength. We want runners to strength train. So for economy of movement, improved form, training, racing, and we recommend this kind of plyometric-based training program to prevent that. This is one of our classes in Central Park.
Looking good.
Earlier in the year, so we have people do a combination of kind of running and strengthening. This is about 6:15 in the morning back in March, looking at some of the stuff we've been working on with them. So putting it all together for our patient at the beginning. Rapid injury diagnosis. Early running, every running injury has multiple causes, both inside your body, externally, some of the things you're doing. You want to think about both diagnosing and preventing some of the common running conditions we see, because getting people back into running is a complicated process, and we want to make sure they don't keep replicating things. So my conclusions from this would be short stride, high cadence running, thinking about really getting that cadence up to 175, 180 if you can, total body strengthening, and I think those are the keys to think about injury-free running as you go forward. Thank you very much.
Exactly the time, 1 hour. Any questions? Time for questions? Yes, no?
Thank you for an excellent presentation. My question is, do you have maybe some prognostic variables that you can predict someone who comes to your clinic and then you say maybe you should start with some strength training before you will start to running?
Definitely. So we really try and encourage the strengthening and the running simultaneously. The way we kind of explain it in meal terms is that the strength training is like the dinner and the running is the dessert, and you don't want to start with dessert. And so we really think about getting their body ready to run before they start running. So things like a single leg step down test off a bench is a very helpful way. Even a 12-inch or 18-inch ledge is fine. Just to look at pelvic strength. We have I didn't show that. We have a whole kind of step down thing we do. But we really encourage both things together. We try and get them on a 3-4 week preventive strengthening program before they start. That's the biggest mistake that we see with the new runners, is they don't do the strengthening piece. And so that's where we start with that.
Thank you.
Please.
There's a trade-off between stride frequency and stride length for optimizing cost of running. Is there an app that tells you what combination you should choose in regarding to your heart rate for minimizing energy cost?
And again, these are guidelines. Some people run comfortably at 170 or 165. Some people get up to 180. Even in a run, you may be at 180, 160, 175, whatever. So it's not, you have to be, getting people, most people overstride and their cadence is too slow in general, which leads to some of the problems we've been talking about. But what we try to do is educate them on what they should be shooting for, what it should feel like, and then kind of find that balance. And you're absolutely right. When you shorten your stride, the efficiency piece goes down slightly. Not as much as you might think, but it goes down slightly. The benefit of that is you're not hitting the ground as hard, and you can run injury-free for a longer period of time. So there's not a perfect answer to that question. It's a good question. And the answer is you have to kind of play with it a bit to get what it feels like. Most people don't have any idea that's what they should be thinking about, and so educating them about that is probably the first step.
I was going to ask pretty much the same thing.
Oh, all right.
The 180 cadence is a little hard for beginners.
I think so, and I think we try and get them to learn what it feels like, and try and kind of find their right place within that. Most people, when they haven't been thinking about this at all, are kind of 150-ish, which is much.
What about power walking?
So power walking is an interesting thing. It's a very different, much more hip motion. It's a very different dynamic than either of these. We have kind of walking and running. We haven't looked at power walking per se as much. Their injury rate isn't really reported as well, and I haven't seen much on that. But I don't know. Interesting.
There's an idea there.
Yeah.
Do you recommend doing a program of running that they run flat out, or that can increase every day their speed, or they have to take rests?
You mean in terms of a training program? Yeah, so I think, again, everybody comes in very differently. We start with about three or four times a week of running, and then a couple times a week of strengthening is generally what we've been doing, and then getting people familiar with the foam roller for some kinetic chain management. The mistake on the over-enthusiastic person is trying to do it every single day, which is probably not as helpful for most.
What do you say about running on softer
Surface,
such as on the beach, thick grass?
Yeah, that's a good question.
And another one, opposite to the minimal shoes, so more absorbed shoes.
Oh God, yeah.
So this is also a bit.
Yeah. And so two good questions, and they're related. And so the first question is on surface, and there's been work done on both. Some saying that the harder surface leads to higher injury rate. Some saying that the softer surface is not as good. And I've not been as
Depends
clear
how
on-
much soft.
Well, I don't think there's a right. So here's my opinion on this, and this is my opinion. My opinion on this is that if you're mechanically sound, meaning your stride is in a reasonable place, your foot control is reasonable, your strength is good, your training program is reasonable. If you're mechanically a sound runner, a soft surface probably maybe potentially helpful for you if it's not too soft. If you are mechanically challenged, you're kind of falling into valgus, you got a weak glute muscles, your stride length may be problematic, etc. I think that the harder surface does not overemphasize those mechanical flaws as much. So my feeling is that you need to earn a softer surface by getting people mechanically more sound. But that's just been my feeling, and I haven't seen anything on that in terms of figuring that out. Now the hook shoes is an interesting one. Again, I haven't seen much on studying those yet, but in terms of thinking about that, I think it's a similar issue, that there's just much more give in that shoe. And again, getting people mechanically in the right frame for those, kind of short stride, high cadence run, etc., probably lets those work more effectively, but there's so much more give in that shoe that if you're flawed, I think it can exacerbate some of the problems.
Thank you.
No, you don't want any coffee? You don't have any time for coffee? I
It's
don't
related
mind.
to the last question, like for your experience for barefoot running, and injuries frequency, did you see any differences?
Increase.
Barefoot running.
Barefoot.
Barefoot.
Oh, barefoot.
Yeah.
So barefoot's been a very interesting one. So to me, the thing I like about the barefoot mechanic is that, and there was a study that I didn't put in here, where they took people who'd run in shoes their whole life and didn't instruct them. They just put them in the lab. And we did a smaller trial of this at HSS, and we had them just run barefoot across the force plate. And what they did, if they'd never run barefoot and they were given no instruction, was they shortened their stride and they had a less ground react. Makes sense. You don't want to hit your foot so hard on the ground. The problem is that when Born to Run came out and everybody was enthusiastic about being, so the Born to Run was a book about this tribe of Mexican, I guess the term is Mexican Indians in northern Mexico who had run for centuries barefoot and then with these minimalist type shoes, and so then all of a sudden in Central Park everybody wanted to unleash their inner Mexican Indian. And so we had a lot of people coming in with those things. I think the thing we can learn from the barefoot mechanic is that it puts you, I think, in a better mechanical position, but I don't think you need to run barefoot to get the benefit of the barefoot mechanic. That was the conclusion we came to with looking at that, was that you can obtain the benefits of barefoot running without running barefoot, because running barefoot puts much more load on the posterior chain, so Achilles problems, hamstring problems, the injury to the foot itself if it's not used to doing that over time. So I think we can learn from the barefoot mechanic is closer to what we want people to do, but I don't think you have to run barefoot to do that. All right?
Okay. Thank you very much.
Thanks.